Chad McQueen from CHEST 2015 for PAH.TV. I'm here with Dr. Levine from the University of Texas Health Science Center. Welcome, Dr. Levine.
Thank you very much, and thank you for inviting me.
You're welcome. Well, we're here today to talk about a symposium that you chaired on Monday, I believe, that dealt with a variety of PAH issues. So can you talk to a little bit about the issues that you discussed, and maybe we'll begin with the pregnant patient and what you would do with those types of patients?
This session that I was involved in had to do with pregnancy in a whole host of different disease states, and I did the PAH segment. And I think the main thing that we should all remember is that even though outcomes may be improved from the prior era, after patients have become pregnant and deliver with PAH, still all the guidelines, whether it be from the European respiratory guidelines that just came out in August of 2015, or the ACCP guidelines, or the JAC guidelines, or the WSPH guidelines, is that we are still recommending, or they're all still recommending, against or discouraging pregnancy in these patients. These patients still have an unacceptably high mortality rate, and it's, if all possible, when you see a patient, actually when I see a patient in a childbearing age, we always counsel them the very first visit when they're coming for their PAH visit. There are certain circumstances, as was in the case that I presented at the session, where either a patient is coming to you already pregnant and did not know they had PAH, or they, for some reason, they're coming to the OB ward and we didn't know they had PAH. And I think that those cases where it may be too late to do anything about it, or if the patient wants to or insists on continuing with the pregnancy, then we need to talk about how to go about that. And I think the main point of that session was how we went along with this patient throughout her pregnancy and delivery, but also the fact that you can't do this alone, and it is a team approach in terms of getting these patients as good of a chance as they can get, and that means a multidisciplinary approach of getting high-risk OB and CT or CT surgery, anesthesia, cardiology, pulmonary, nursing, respiratory therapy, perfusionists in case the patient had a problem and had to crash on ECMO. There's so many people that are involved. I think one of the points I pointed out was the best route, the best plan for this patient, if they are going to continue with delivery, is to have them transferred to a center that has a team already set in place. And I think those are things that are very important that came from that session.
So when you think of the patient that is pregnant and has PAH, unfortunately, do you treat them with traditional PAH drugs, or what is the approach to taking care of that patient once they're diagnosed?
So that's a really good question. I think one of the things that we have to remember is that some of the medications are teratogenic, and if you find a patient in that, you have to get pregnancy tests every month with the ERAs and the SG stimulators. All of them you get a pregnancy test every month, and those drugs are not going to be given to the patient unless they have their pregnancy test. So we know if a patient is pregnant that obviously those drugs cannot be used. Depending on when the patient is found to be pregnant and when delivery may happen and how bad their PAH is, then you may treat accordingly. So if a patient's very early on, she just finds out she's pregnant, and she may be a class 2, a WHO class 2 heart failure patient, she may be okay to be on orals and watch throughout the pregnancy. As the patient progresses in time, though, I usually like to start a prostacyclin at some point and make sure that they're on that and it's stabilized before she has to deliver. Most of our patients are on some type of IV form of prostacyclin or prior to delivering.
Now, I know one of your passions and also a topic I believe you spoke about was transplantation care in patients with pulmonary hypertension. At what point do you consider listing for transplant now, and what's your general approach to patients post-transplant with PAH?
That's a really good question too, and as we know, there's a beautiful slide from the International Society of Heart-Lung Transplant that comes out every year in their registry, and it really shows a beautiful progression of how we've been transplanting patients with PAH. And patients, really the percent of patients who get transplants for PAH have been decreasing over the last several years. Ever since like 1995, after epoprostenol was FDA approved, and then as the progression continued when other drugs were added onto that approval list, we see the numbers of transplants for PAH being delayed or not having to be done, such that now out of all transplants being done in the world, probably less than 3 to 4% are done for PAH at this time, and that's coming down from 10% in the past. I think in terms of looking at these patients and being able to treat them, I think we have a longer period of time if we are delaying, if not halting, the need for transplant. But patients who are either class 3 or class 4 patients who are either on medicines or just starting medicines should definitely be evaluated at a lung transplant center if they're not improving with medications. And I think no transplant center is going to ever look away and say, oh, they're too early or that. I think we always like to know about them early, and if we have to follow them every year for many years, we're happy about that. So I think the indications for referral to transplant is, number one, if you're on medications, maybe if you're class 3 or on even top medical therapy, either IV or combination therapy, and you're still not improving to the point you want your goals to be, and we know goals are pretty aggressive nowadays. We want people to be having class 1, 2, heart failure signs. Then I think it's good to refer. Listing patients is up to the transplant center, but I think all of those things come into play. We know the lung allocation system isn't always beneficial to the PAH patient, and that's why we always talk about getting the patients to us early.
So another thing that I know is an emerging, could you tell us a little bit about the InFocus program and what that's all about and what your role is in it?
Well, this is a very incredible opportunity for people to learn a lot about PAH in a new educational forum. This is a program that we're working with the Chest and France Foundation regarding getting a interactive approach to learning PAH. We are doing a 7-8 hour day program that people are coming for kind of a broad view of PAH, but learning not just by lectures. They're interactive, they're making cases, they're presenting cases, they're playing games, they're learning PAH through an interactive role, and it's not just a sage on the stage type of lecture. They are moving, they're working. By the time they leave, they know a lot more about PAH. It's a great program, and we're very lucky Chest has allowed us to start looking at this. What we did the first session at Chest, and we were probably going to be working on that throughout the year in different locations.
So Dr. Levine, thanks for coming by today and telling us about your session on Monday.
Oh, thank you very much.